classification classified the bone defect into three classes: class 1, class 2, and class 3. Class 1, where we have horizontal defect. Class 2, vertical defect. Class 3, combined. But how we will differentiate the difficulties within the same classes? What I mean, if we have class 1, horizontal defect, are all horizontal defects the same? Of course, no. That's why a modified classification to this one, which is called HVC. HVC classification. So each classes will be subclassified into horizontal, which means horizontal, vertical, and high will be classified into S or M, S small, where the defect, the size of the defect is less than 3 millimeter, medium M between 4 to 6 millimeter, and L large more than 7 millimeter. So the reclassification up to this will be H, which means horizontal, S small. So I will know I have horizontal defect, S less than 3 millimeter. If I'm going to say VM, so it's vertical defect with between 4 to 6 millimeter defect, and so on. Now, a third classification I'm going to tell you, and it's found on the mesh textbook, which is mesh classification, where we discussed in the last lecture, where the only defect on the coronal part or concavity in the superior part of the alveolar crest in the concave shape, or tough, and it looks like, imagine, extraction socket with no buccal wall. So this kind of defect, a deep defect, is called tough. Or elevation, where you have defect, it has raise and up, not on the straight level, not on the same level of the bone. Vertical, we already discussed. Buccal, lingual, palatal, where we have defect on the buccal wall and palatal wall. And complex, which any combination of these defects can be related to the complex. Now, how the importance of the classification and the imagining the shape of the defect will have impact on choosing the technique and the bone graft later, as we will know. Okay, now the next question was mechanism of healing, osteogenesis mechanism, or osteoinduction mechanism, or osteoconduction mechanism. Everyone knows the difference between these three, or do I need to explain each one? Explain. Osteogenesis means immediately the bone formation will start, because the bone graft has a bone cells that can start their action immediately. So osteoinduction. Now osteogenesis we finished. Osteoinduction stimulate the mesenchyma, the differentiation of the cells into osteoblast to start bone formation. Osteoconduction is just a space, a scaffold, to give me an area where the cells can come in and do their job. So, any question? So which one is better for us, for the bone? Osteogenesis. The second one, induction. Third one, conduction. Is osteoconduction is a bad thing? No, it's an important thing, as we'll see later. Okay, types of bone graft. Autogenous bone, a bone from the same person, so from the same patient. So we call it autogenous. We can collect it either extraoral or from intraoral, mainly from the chin and ramus. And it's the only bone that possesses the three mechanisms: osteogenesis, osteoinduction, and osteoconduction. The third one, it has two forms because of the histology of the bone, either cortical the outer part, the dense part, or cancellus, the inner part of the bone, or corticocancellus. Each part of this bone has its own advantage and disadvantage. What do I mean? Cortical bone, because it's dense, it has more osteoconduction, which means it can preserve the volume much better than the cancellus. So it can withstand to the trauma coming from outside more than the cancellus, where it might resort quicker with more trauma. However, the end result of the bone formation that comes from the cancellus is much better than the cortical. So if you have noticed here, this is mainly cortical bone. We use it in one technique, one of your colleagues now will mention the technique, to protect the bone placed inside it. This is the cancellus. And do you know, with it, while you are drilling through the bone, you can also collect cancellus or bone from your drill. If you use a low speed, up to 50%, up to 50 RPM, 50 RPM round per minute, without irrigation, you can collect this bone and you can use it later as autogenous, as I will show you later. Or you can collect a corticocancellus block, where you can take the advantage of both types of autogenous bone. Any question regarding the autogenous? It's not related to the bone. The blood supply, they are not related to the bone. But cancellus bone will give us better cells to start for the bone formation. That's why the end better bone formation, the end result of the bone is better than cortical. The main disadvantage of this bone, high resorption rate. As long as you are taking osteoblast, you are taking also osteoclast. That's why it's normal after 3 months, if you place, you might lose up to 50% of your bone graft after 3 months only. That's why in now protocol, it's highly recommended to mix it with something to minimize this resorption, which is xenograft. Now, the second type is allograft, which is bone from same species. In this situation, bone from another human. It's not used in Europe because in some logistic, they are not selling it in Europe. That's why most of your paper and articles that coming from Europe, they are using xenograft, not allograft. And even the doctors who are giving lectures in any conference, they are using xenograft because of this logistic things. So, allograft, what do I mean to focus of the bone we are using from the market? They might be either freeze-dried or demineralized dried. Freeze-dried bone graft, it has a considerable amount of osteoconductive. However, demineralized is less osteoconductive, but because of the demineralization of the cortex, it has higher osteoinductive property. As an example in the market, Max Graft, not Max Resort, Max Graft or Cinobone or Monir A. These are examples in the market you can buy for allograft. Now, xenograft is a bone from different species. In our case, from animal, either porcine, bovine, horse. This is the highest osteoconduction property found in the bone graft, is the xenograft. So its advantage is the same thing, its side effect or disadvantage. We need the bone to last for a long time, but at the same time, we don't want it too long. We want, after time, to protect our bone enough time for the new bone formation to form. That's why we tend to avoid using it, especially if you are applying it in direct contact with the implant. So when we do any bone graft, we'll do it in layering technique. What do I mean by layering technique? In the first layer of bone graft attached to the implant, you can use either autogenous, allograft, or even alloplast. But then the second layer, you can use this xenograft to protect my bone and at the same time to give me the volume I need. So in the market, we have BioOs, Cerabone, and this quick bone. Why I'm mentioning quick bone here? Because within the quick bone, they added the collagen, which, as they are claiming, the maximum time that bone will stay inside the body is 2 years. After 2 years, it will disappear and a new bone will be formed, unlike the Cerabone and the BioOs. But even though I highly recommend neither of them, as much as you can, avoid using it in direct with the implant, in direct contact with the implant. The fourth type of bone graft, it's the alloplast. For the alloplast, I'm going to discuss about only tricalcium phosphate and hydroxyapatite. Dr. Reem, why this type of bone only I'm discussing in alloplast? Because in the market, what you are going to find, it's a combination, either one of them or two of them. For example, Max Resorb, it consists of 60% HA and 40% tetracalcium phosphate. Same thing with Easy Graft Crystal, where it consists of hydroxyapatite 60%, 40% tricalcium phosphate. While Easy Graft Classic and the Power Bone mainly TCP, tricalcium phosphate. Now, if you remember in the autogenous, we were talking about the cortical and the cancellous. Cortical will protect the cancellous. The quality of the cancellous is better. Same thing here in the alloplast. Beta tricalcium phosphate is the cancellous of the autogenous. Hydroxyapatite, it's the cortical of the autogenous. That's why they are preferring of the mixing, and the rate of the resorption of the beta tricalcium phosphate is really high. However, regarding the power bone, there's secret ingredient here, which is the silicate. Silicate, they are claiming that it will direct the negative charges toward the bone, so it will enhance the cells to differentiate into the osteoblast and act like osteoinductive way. That's why power bone, you can say they are all osteoconduction, but this one, it has some sort of osteoinduction because of the silicate. What I prefer, this can touch the implant. This, try to avoid. Now, to be honest with you, even if you use xenograft with a small amount around the implant, maybe nothing will happen. Maybe if you use Max Resorb, which contain HA, 60% HA around the implant, maybe in the future nothing will happen. But as a protocol, if you have the option to avoid it, do it. All the techniques you are hearing in the articles, textbook, they are coming from these principles. First one is the socket preservation, how to do a proper socket preservation. The main issue with the socket preservation is the buccal wall intact or no? This is number one. And how to close this gap. Are you going to release a flap, extend the buccal flap up to the palatal or lingual and suture it? If you did it without tension, you are going to lose the vestibule. So you need to find a way how to cover the hay. The first option, you can use a non-resorbable membrane. The second one is if you have placed your implant to go with healing abutment. Healing abutment, customized abutment, temporary abutment, or the technique I argue to do is after you place your bone, you can take PRF, fold it, suture it as a soft tissue graft over the hay, and if you can make like a liner or Essex with a missing tooth to cover the PRF for at least 2-3 days. The second technique, it's the GPR, and this is the second GPR, guided bone regeneration, means you need to place your bone into the defect, cover it with a membrane, stabilize everything, and suture. And this is the technique we will practice today also. It's called GPR, guided bone regeneration. The third technique is bone block graft, or you can use either as a plate for a technique, take a cortical plate, screw it, then you will have a box. Fill that box with autogenous bone according to Hori technique. In this case, you don't need membrane suture. Or you can use a block as a corticocancellous, attach it, screw it to the defect. However, the rate of the resorption with this technique is higher than this one. The third technique, or the fourth technique, which is used in case of class 2C PERT. What was the class 2C PERT? Vertical, which is more predictable in this way. It has high predictability, which include, it's interpositional bone graft or sandwich technique. Another name, it's sandwich technique, the nickname. You can make a segment, cut the segments horizontal to vertical, so these segments will be separated. Keep it attached to the mucosa. Move it up, fixate it with the plate, microplate or mini plate if the defect is big, and then with the gap, fill it with the bone. This is the highest predictable technique with the least resorption amount. Interpositional bone graft. The fourth one is destruction osteogenesis, which is do the same segment and keep it attached to the original place. Put this device where there's lower plate and upper plate. Lower plate attached to the mandible or maxilla. The upper plate attached to the segments. And after 1 week, what is the first phase of healing, of bone healing? Clotting. At the end of the clotting phase, the tissue called callus. So every day, if you move these segments 1 millimeter up every day for 5 days, this callus will expand like a gum. So if I need 5 millimeter vertical, I will go every day 1 milli. So after 5 days, I will reach 5 milli up. And then I will fix it for 3 months. We'll continue the healing process up to the bone. The advantage of this technique, it will expand the bone and the tissue around it, not only the bone. And we can include the expanding within the ridge splitting. Actually, each one of these, we can make a whole lecture or a whole workshop for each technique of those. So this is as, let's say, introduction to them. Now, the next subject is the principles of bone graft. What I prefer, we can go with the past principles, which P, primary closure, A, angiogenesis, S, space maintenance, the second is stability. We have the lecture. This is the lecture I promised you to put in the group as a PDF, the full lecture of this. Because we discuss each one in details, how we'll do it, what are different techniques for each one of them. Now, we'll go to the types of membranes. Types of membrane, 2 types mainly. Resorbable, non-resorbable. Give me an example of the resorbable. Collagen membrane, another pericardium. acellular dermal membrane, and magnesium membrane. Non-resorbable. Titanium mesh, PTFE, and titanium reinforced PTFE. The membrane that was within the socket, it was this one, PTFE membrane. Titanium reinforced PTFE, it's the same PTFE but with a titanium plate. We use this one if we need to reconstruct a defect in the buccal to give it, the shape, or the vertical to protect the bone. Titanium mesh, it's a good membrane. However, the rate of the exposure within titanium is high, especially be careful to use it with the thin phenotype mucosa because it will expose later. And even sometimes to detach it for removal, it's quite hidden. DPTFE. The first generation was the EPTFE. The DPTFE, I think they added extra layer to protect it from the bacteria. So most of in the market, they are DPTFE. This is what However, have you heard this magnesium membrane? We use it, we classify it as, so magnesium is a metal. So this membrane, it's a metal. It has the property of the metal. So you will have the advantage of the metal. At the same time, it will disappear. Complications. The most complication I want you to be aware of is wound dehiscence. Because if your wound is open, infection can start, just like this case. Infection can start, and this infection can ruin all your bone graft. If the bone material got infected, you have to remove them, or some of the bone will come out. That's why if we can be sure the flap sealed, as we'll know later with the scoring, it's always not an option. It's mandatory. It's a must. We have to do it. If we have adapt, we cannot be sure for complete sealing, and some area will be exposed, so maybe it's a good idea not to go with a membrane like a PTFE. Even if it's exposed, it will not affect the underneath bone. So the bone should be always covered to avoid any complication. Now, to avoid the wound dehiscence, now with the scoring, we'll see how we will be sure the wound will not open with us during the bone healing in a practical way. The flap scoring, it started before you hold your blade, or once you hold your blade, you need to make your first incision in the flap. This is where scoring started. So first step, because the end result or our goal is tension-free primary closure. So flap design will affect my scoring. Flap elongation, how we will do it, and the wound sealing, which are the sutures. Flap design, how my flap design will affect the scoring. If we are working on the mandible, always keep your crystal incision in the midline. Now we have planning to do bone graft. Your crystal incision, keep it on the midline. While on the upper, keep your incision on the buccal. Why this one in the middle and in the upper in the buccal? Because in the lower, the both sides of the flap, the buccal and the lingual, will be expanded together. And we'll know how we'll expand both sides. While on the upper, only the buccal will be expanded, not the palatal. Palatal, whatever you do, it will never be expanded. And we need some sort of the tissue, elastic tissue, to withstand the tension can happen. If you made your incision in the midline or more toward the palatal, imagine the buccal wall, the buccal flap wants to stretch, and the other side is fixed, it will open immediately. That's why always directed to the work, the buckle. And same principles of any flap. If I'm going to use envelope, I have to extend 2 teeth anterior, 2 teeth posterior. If I want to do any vertical, I need to extend it 1 tooth and then I will go with the vertical. In some cases, I can extend to extra tooth before the vertical in case I have mental foramen, for example. I have, maybe it's the canine eminence. I don't want my incision to be there. It's very thin, the mucosa there. Or the defect area, yes, for sure defect area. This for sure. But what do I mean? Don't be preservative in case of bone augmentation. Because if you do a long flap in a proper way and a short flap in a proper way, both of them will heal at the same time. This 2 weeks and this 2 weeks. Actually, this one heals better than this one. Do you know why? Because here I extended my buccal flap more lingual. The extension was much more than needed. So my buccal flap, the connective tissue of my buccal flap attached the epithelium of the lingual flap. That's why it took longer time for healing. While this one was perfect. That's why for flap elongation, the first technique doctor said, which is we need to cut or separate the periosteum from the mucosa. Actually, this today workshop, now today all of us will do this technique. We'll separate, 1 line incision is enough. See the inner part of the flap, identify where's the mucosa, a new blade recommended, 1 line, and that's it. And bring a blunt scissor with a blunt dissection. You know how to do it? Blunt dissection. Place your scissor closed, open, out. Then come here. Place it closed, open, out. It will open all the flap with you. Or will separate all the periosteum. And this periosteum will be separated. So we will have 2 parts. One inner part, like inner flap, and this flap will be expanded. Because the periosteum will prevent the mucosa from stretching. This is regarding the buccal flap, either lower or upper. Regarding the lingual, with the periosteal elevator, just move it up, detach the mucosa from, what is the name of the muscles down here? Mylohyoid muscles. Mylohyoid muscles. And the flap will be expanded. And don't forget to make pocket in the posterior area and pocket in the anterior. In some textbook, within the premolar level, you can make vertical incision like this one, but you don't need it. The amount of extension of elongation by this technique is much better. It's high, really high. You don't need to make that kind of incision. How much enough elongation? Once you put the flap together and the buccal flap extended at least 5 milli without tension that it needs to go back, this is enough. Extend it over the lingual or palatal side. So in this case, you'll know it's enough. But how to suture? That's why I recommend to do 3-level suture. The level 1, membrane stabilization. Level 2, flap approximation. Level 3, water seal suture. I have quick case, we can demonstrate on it. These are the 3 levels of suturing. Now, regarding the suture technique, most of the technique we are using here are interrupted and deep mattress. And if anyone preferred continuous or continuous with lock, it's an option. But these 2, upper, deep mattress, and interrupted, they are the main techniques we are using for the bone graft. And For the material, we are using PGA, resorbable suture, and PTFE, non-resorbable suture. What is the advantage of the PTFE? PTFE, because it's monofilament, the bacteria will not attach it. So it will minimize the rate of the infection. And the 3 level of suturing. This patient came, she has a bridge, 2 implants. One of the implants failed and is moving. After we remove the bridge, this was the result. Clearly, we don't have any buccal bone here. So we open the flap, we remove the implant, we clean all the granulation tissue, and this is the end up. What is the type of, according to mesh? To separate, +1, only horizontal, trough. So what we did, we placed our implant. I cut this area with the ronger, crushed the bone, and placed my bone directly over the implant. This is level 1 of implant. And then, what was the name? Allograft and xeno? Yes, a mixture of allograft and xenograft was the second layer. If you have noticed, I can place xenograft here. Why? Because the implant, there's bone covering the buccal plate of the implant. What membrane I need to go? I went with the magnesium membrane because I need something to protect my bone from the lip, from the pressure of the lip. That's why I choose the magnesium membrane. Now, to suture it, 3-level suture, as we mentioned, to close our flap. After scoring and after everything, remember when we separated the periosteum down? Now, you need to do horizontal matrix suture to that piece of the periosteum with the palatal tissue. So, periosteum down, out, palatal, out, and then go palatal again, horizontal matrix, the periosteum, and then suture, and then make the knot. This suture, it will do nothing to my flap, but it will stabilize my membrane. You see how my membrane is stabilized here? Now, the second level of suturing, I need to bring, resorbable, yes. Now, I need to bring my 2 flap close enough with kind of suture where I need the tension to be directed away from the edge of the flap. This is the technique of the suturing, deep matrix suture. Deep horizontal matrix suture, which this is the buccal, this is the palatal. 8 millimeter from the edge of my buccal flap, I will go from outside to inside, and then I will move my stitches from inside to outside of the palate, and then outside, inside palate, inside, outside buccal, and then my knot. I will do this one along of the flap, maybe multiple times, depends on the length of my flap. So in this way, my tension will be directed over there, not to my opening up, plus my 2 edges are reapproximated. Now, why I said 8 millimeter, maybe some cases you need only 5, or maybe you need 10. It depends how much amount you need to expend. You don't want to extend to the other side, and at the same time, you don't want less. So you need to measure. Bring the flap, and you will know how much amount, or where you need to do your matrix. How millimeter away from the edge of the buccal flap you need to start it, the suturing. Last level, simple interrupted. If you have noticed here, this is resorbable. I'm not going to remove this suture, so I need suture to resorb. That's why the first level should be resorbable. Second level, non-resorbable, PTFE. The third level is also PTFE, where the two edges of my flap should be everted. Everted means the inner part of each side of the flap should meet each other. Not epithelium, epithelium. Epithelium, connective tissue, or connective tissue with epithelium. No. I need the two inner part of the flap to meet each other, and I will do my interrupted sutures. Now, in the textbook, if you extend the flap, you say the buccal flap, and it goes 5 millimeter to the palatal without tension, without it coming back, that's enough. So no need to overextend, and of course you don't need underextend. Overextend, it will complicate the healing. Underextend, it will make the case worse, where the flap will open and you will lose all your bone. And that's it.